Oh, it's so hard.
I'd be happy for the rest of my life, yeah.
Oh, we're doing that.
So like pediatric dentistry. It's only 4 pages, but yay, it's for us.
Oh, you got
It's
one.
only 4 pages.
No, it's good.
All right, so the lab for the dental restorative materials. Kind of, for the restorative materials. And then we'll do the pediatric.
Yeah.
Throwing us for a loop today, aren't we?
Keeping you on your toes.
Like I said, when I walk in, I sit down, I'm like, okay.
Okay, so we talked about liners and bases and the varnish. So in the lab, when we start, we're going to do composites and we're also going to do amalgams this afternoon. So those that have seen us doing composites, you know what our assistant's job is, to hand us the liquids that we put on the teeth to prepare the surface, okay? And so that's what's called the bonding agent, okay? That's what helps the composites bond to the tooth. Before composites, they would bond to enamel, because enamel, when you etch it with that acid, it gives you a good surface to bond to. It's a rough surface that grabs on. The dentin, before, it wouldn't bond to it, okay, until these new bonding agents. Now you get a restoration that bonds to the tooth, okay, enamel and the dentin. So bonding agents are adhesives that are used to improve the retention between the tooth structure and the restoration. Okay, so they're just increasing the bond, increasing how well that filling is going to stay on that tooth. Bonding agent systems and steps vary greatly among manufacturers. The dental assistant's role is to prepare the material for each step to keep the operating field clear, debris, and moisture. And if you've seen Yesenia, my Yesenia and I work, and I'm assuming Dr. Cervantes Yesenia and his work, Yesenia, Yessie and I, we don't really talk too much unless I'm changing, I'm doing something different. She knows by what I'm putting on the tooth or what burr I put on, what's next. Okay, and that's what you need to pay attention when you shadow. If you know, see what she's always one step ahead of me. And if I go like this, she knows that we're going back. You know, and we don't really communicate other than it's mostly sightseeing. Yeah, and you can, it's like a big dance. Okay, but again, you'll learn that the procedure is just repetitive. But she's always anticipating what I'm doing and always has the next step already in her left hand. She's either got the bonding, the primer, the edge, the whatever instrument I need, always ready, so I don't have to ask for it. And if I, out of the corner of my eye, see what she has in her hand and that's not what I need, I'll just go no. And so then she goes back. So pay attention to that when you shadow on what we do. Anyway, we've got this one, we've got this one. This is by Premier, that one we don't have. But anyway, there's different types of bonding, and they're all good. Well, they're not all good, but usually the major manufacturers are good. This is a really popular one. And again, we're trying to avoid sensitivity. And this is, in our hands, we really like this, and we switched to this many years ago. And it's, I mean, every now and then they come up with a newer, improved version, but Clear Bond is one of the, or SE Bond is one of the more widely used ones because sensitivity when you place a composite is very low. But we do have tenure and tenure S for other materials that we use. So armamentarium, what you need, obviously you need your bonding system, whatever that may be. Okay. You need applicator brushes, what you're going to apply that onto the tooth with, your water syringe, curing light, and shield. Okay. This looks like my curing light. Dr. Cervantes has something that looks like this. Again, you've got the shield to protect your eyes and the doctor's eyes. Jessie has this on ours, and I let her cure. If I'm going to be looking in there, then we need this because I need to protect my eyes. Usually she looks through that. Now, you need to be careful with these because they are expensive, okay? And that's what these are. They dropped my tip the other day, and these are about $200 a pop. The little, this little guy. Okay, so it was by accident. I mean, I didn't get mad. I mean, it's gonna happen. But you need, this machine is about $3,000. This one's probably about $1,200. So any machine, any light, I mean, you can get anywhere from $500–600. But my Sapphire light, I can cure a composite down to 4 millimeters in 2 to 3 seconds. I can put it on there 2–3 seconds, and it's cured all the way 4 millimeters. The less expensive machines you may have to cure for 20 seconds. You know, so and again, 20 seconds is a long time. So this machine is really good. Even Dr. Cervantes, I think his is 10 to 15 seconds, which is, I don't know how he does it, but he does. I mean, they cure, it just takes longer for that light to penetrate. The light isn't as bright. But just be careful with it, especially mine. If we are using ours, where it's got a little docking station right next to the side, and you need to make sure that it sits right, because sometimes the design on it is not very good, and it sometimes doesn't. Yeah. So just make sure that it goes there and it's really cradled in there right. When we did a crown, one of these was on the counter and they're black. So they were cleaning, and so they didn't see it, and so while they were cleaning, they hit the tip and it just flew off the tape. I mean, it's just a mistake and it happens, but just be aware that these tips are probably, about
Coming out of your paycheck?
No, well, you may go to an office that they do that. I don't do that. I mean, I know they didn't do it on purpose, but you may go to an office where if you do bring something, it's coming out of your paycheck. So just be aware, because.
Whole paycheck.
Yeah.
So
Good
you
luck
need
surviving.
the curing light. Timer, you can have a timer. I don't use a timer. I kind of count on my head, because again, composites are technique sensitive. Not like amalgam. You can put amalgam underwater and it's going to work. These guys, you've got to count, and you etch for 15 seconds. You put the bond or the primer for about 20 seconds. Air dry. You put the bonding agent, and you thin it with air, and then you cure it for whatever time your light says to cure, and then you place your composite. But I normally count, 20 seconds, kind of tap my foot, because that you do have to wait 20 seconds for the primer to stay in there, again, because it prepares the surface. But the light is a quick step for me. So procedures to place the bonding. So the preparation is going to be prepared, then we're going to put, if we need to put a base or a glass ionomer or whatever, that's going to be placed. First thing is you put the etch to roughen the surface only on enamel, okay, or some dentists do a total etch, they call it, and you etch the dentin as well. Then the bonding agent, depending on what you're going to use. Some bonding agents, we use a two-step, 2 bottles. One's a primer, one is the bond. There is a bonding agent which is 1 bottle, and I don't know what Dr. Cervantes is going to put out today. It may be the 1 bottle where it's kind of all in 1 step. Okay, so if it's 1 step, then you leave it there for 20 seconds, air dry and cure. Where ours, you have to put it 20 seconds, thin dry, then put the other one and cure that one. So it just depends. So there's 1 steps and 2 steps, and then you light cure it, and then you put your restorative material over that and cure that. Okay, so that was the composite. Okay, so you're going to prepare it, and we'll do it this afternoon. We're going to etch it, primer, bond, and then we layer on the composite. And you light cure it. And then you shape it, polish it, and you're done. Okay, for amalgam, okay, when we're doing an amalgam, this is on the test, I believe. The machine that we use to mix it is called the triturator. Okay? And then, what we need as a setup for the amalgam, I think there's a question that asks you about what's the setup for an amalgam. So you need an amalgamator, you need the amalgam capsule, you need an amalgam well, you need a carrier and condenser. Okay, this is the one that, like ours, this triturator right here on the right side. And we have one good one, and then we have one that's not so good one. There's a loose screw in there somewhere, but we don't do too many amalgams, so we just have to use the good one whenever we need it. But today, if we're doing, well, either him or I will have the bad one, which it still works, it's just loud. It just kind of wobbles, but it works. These are the capsules, pre-measured capsules. Okay, and to activate them, again, I told you there's a barrier there, so there's this little plunger. You're going to either push it up against the table, or if you can do it with your finger, but they're kind of hard. So what that does is it breaks the barrier, or the compartment there where the mercury is, so that it combines. And then you put it in the machine, and a triturator is kind of like when you buy paint, and they put it in that machine to mix it. That's basically what it's doing, mixing it real fast. So this is what's inside the capsule. You've got, again, the capsule, the lid, and then some pestle to mix things together. It's going to shake in there. And you got the mercury on one side, and then the amalgam powder. You've got an amalgam well, which is after it mixes, you're going to put the metal in here, the filling material, and that's, it kind of falls all the way to the bottom, so that when you're putting it in your carrier, it's not running away from you. Okay, and at first it's kind of tricky, and when you try to load it in there, it doesn't want to stay in there. You put it in and it falls out. You put it in and it falls out. And there's a trick to getting it to stay in there, and you'll play around with that. This is the carrier. Okay, here's you pack it into here, and it's got two sides, usually a large side and a small side. And depending on the size of the filling, if it's a real small, child, and the teeth are this big, you usually just fill the small end. So you fill the big end, and it all just kind of falls to the side of the tooth. If it's a big tooth and a big preparation, then you fill both, and the dentist will put in the small side, flip it over, put in the large side, and then he'll hand it back to you and say, I need more, or that's good. And then metal will set up, so whenever you're done filling it, make sure you take out the metal from what's in there, because if you leave it in there and it sets up, then it doesn't work anymore. It stiffens up in here, and you've got to cut it out. Or some of the girls, they use a lighter to heat it up, and it shoots it out. Okay, so using the amalgamator, you set it normally here for 10 seconds, but we'll set that. You activate the capsule by pressing the back of it. You put the capsule into the prongs of the triturator. You close the cover. It mixes. Then you open the cover and remove the capsule. It says to avoid touching the amalgam. You've got rubber gloves, so you're not going to be touching it. But you put it in the mixing well. Then this is where you're going to pack it into the carrier, pass it to the dentist, and then again you're going to repeat loading it until the restoration is filled. Sometimes you're going to mix another one depending on how big it is, or 2 or 3. Sometimes we build up a whole tooth out of amalgam. Sometimes we'll ask you just to hand us the whole ball, and we'll put it on the tooth and you mix another one. Again, depends on how big it is. Again, and at the end, expel any amalgam inside it, so it doesn't set up. And we normally just suction it up into the suction onto the trap. All right, mixing glass ionomer. So that was amalgam. We did composite amalgam. We're gonna mix some cements with Mike, and he'll bring some of his cements. So again, I'm assuming all the ones that he'll bring are just either they have a little tip that when you shoot them out, it mixes it automatically. And you guys have probably seen our mixing tips. You put it on the edge of the cartridge. It shoots one paste on one side, one paste on the other side, and as it goes through that little funnel, it spins them around, and then they're mixed at the end. So he'll probably bring some of those. He'll probably bring a triturator and mix that. So we'll practice those. Again, the important thing about glass ionomer, it chemically bonds to the tooth structure, and they're mostly used for cementation of crowns and bridges. Okay, I think that's a test question. The most common use of glass ionomer is cementation of crowns and bridges. Glass ionomer materials. I don't think you need to know any of that. Steps for mixing glass ionomer. Mike will go over some of that again. It should be creamy. If you do mix by hand, you want it kind of creamy. You have to see it. When we mix it, you'll see it. But when you mix it and you tap it with your spatula, you put it on, and as you lift the spatula, it should stick to the spatula for about an inch. Okay, if you go like this and it doesn't stick, it just falls immediately, then it's not thick enough. Or if you go here and it sticks and you lift it and it's still sticking, that's too thick. So about an inch. When you draw it, it should be a little stringy. You lift the spatula up and it'll stick, and then about an inch, and then it'll break. And that's a good consistency. And usually all cements will be about like that. So when you mix it, you put it inside the crown, transfer it. Go over that. Anyway, this is the GC again, glass ionomer. Again, we have these. You can see how it comes out in 2 tubes. You just press here and it automatically mixes the exact amount. If you don't have one like this, then you just kind of estimate, and we've got a couple cements that you just kind of estimate a little strip of this and a little strip of that, and it should be pretty close to the same. But this one is Reliax, and we have that here. And again, it mixes the two, or squirts out the toothpaste, and you just mix it. Again, 10-15 seconds max is what it should take you. You know, it's not, you just get in there, mix it, mash it together, and you just want to get rid of all the streaks. Usually there'll be different colors, a cream and a white, and you don't want any streaks in there on anything you mix, because then it's not mixed properly. So make sure you mix, kind of mash it around like butter, put it together, mash it, put it together, mash it, and then you're done. It shouldn't take too long to mix. Okay, we're going to do an amalgam restoration. Again, we talked about the setup a little bit ago. I think there's a test question here because there's a star. So you need, again, your basic setup: air water syringe, cotton rolls, topical, high and slow speed hand pieces, dental burrs. I'll show you and you need your amalgamator or triturator and carving instruments. So just know what's in a setup for the amalgam. I think it's, yeah, and I think the question for either composite or amalgams, it says what is needed for an amalgam setup, and it'll give you, 5 or 6 things, and then one that doesn't belong or something like that. So that's sort of what the questions are like. But so know what's in there and try to recognize what is not in there. So it may say you need an amalgamator, hand pieces, and an ice pick or something like that. So make sure that you don't select that one.
Sledgehammer.
Yeah, sledgehammer or a tire, right?
A tire.
So this is kind of what a setup would look like. You've got your hand piece, you've got your capsules, This is a little dappin dish as an amalgam well. Your carrier, anesthetic, burrs. Burrs is a common thing that's forgotten. And then you have all your carvers and condensers. Your water tip, anesthetic. Okay, this is just a different setup. Same thing, you've got your calcium hydroxide over here, DiCal, all your instruments. This is my setup here. Again, on the assistant side, this is what they have. Okay, so you've got your carrier, your amalgam, DiCal. This is what's called a DiCal instrument. Okay, and it's like a little explorer, but it's got like a little ball right at the tip. And that little ball helps you pick up just a little bit of that DiCal to put right where you need it. If you use an explorer, you can use an explorer, but it doesn't pick up enough material. For whatever reason, that design, that little ball, it just kind of scoops up and you put it inside the tube. So it's called a DiCal instrument because it picks up DiCal. This is articulating scissors or pliers. Your carvers or burnishers, condensers. This is called a matrix band. Okay, matrix, it just forms a matrix or a form for the cut part of the tube so that the filling can go in there. This is the amalgamator we have. And then don't forget the hand pieces, because we need those to cut. Okay, for composite, we kind of talked about that a little bit already. Okay, so this is the setup for the composite. This isn't my setup, but again, they've got bonding agent, the composite compules there. This is the carrying, the composite carrier where you put the compule. Here's your brushes for the bonding. This is probably a liner or a flowable composite. Oh, here, no, they've got the liner. Time lane, I don't know what that is. This is either a liner or this may be a liner, I don't know. This is their curing light. Okay, this is a small light, and then this is my setup. Again, on her side, she's got the composite with the carrier here. You load the composite there. The matrix band, the micro brushes, etch, flow, and then the instruments that I use. And then on my side, I've got the basic setup: a spoon, a couple spoon excavators, a small spoon, the large spoon, and the hand pieces. And then right behind the patient is where we have the burrs, the shade guide, and the anesthetic. So again, wherever you go, the setups will be different. Dr. Cervantes probably sets it up different than I do. Okay, so it just depends on what they like and what you like. Whatever works. Some offices, you know, the operatories are set up different. Where here we've got behind the patient, we've got this counter. Some offices you may not have the counter behind the patients, it'll be behind you, so your setup is going to be different. So it just depends where you're at and how you set up. The curing light we talked about. I don't think we need to go over that. We'll do that this afternoon. Okay. Questions on the lab? Until you do it, some of you have seen us do it, but it's just repetition. Just repetition. The only thing that may change is what you place down underneath the filling material. Whether you're going to put a varnish or a liner or a base. Those are the only things that may change. After that, you're going to apply. Yeah, it's the same thing. If it's a small filling or if it's a big filling, you've got to do the same thing for both. If it's a big filling, obviously you're going to use more filling material. That's it. Okay. All right, kid dentistry. Who wants to work with kids? Anybody? Really? In pediatric practice? Let's see if have you told Dr. Cervantes at all?
Yeah, I talked to him before about it.
So we can maybe try to get somewhere to shadow.
I went to Dr. Bunch.
Dr. Bunch?
Yeah, right. over
Yeah,
there.
right across the street.
I went there I was there on Monday.
Oh, nice. There's a new, we just met a new, they just opened a new pediatric practice on Oracle. Have you seen it?
Mm-hmm.
It's really nice. I met the husband, who's a general dentist, and he was out just meeting the doctors, kind of doing marketing for the wife, who's the pediatric dentist. And they also, I've referred a couple of patients over there already, because she does special needs patients as well. They've got like a not a surgery, but a large operatory where they can bring in an anesthesiologist and do special needs in there as well. So, but it looked like a really nice practice. But if you're interested, or we can talk to that. You can shadow there like you a day a week or whatever. And that's a new practice, so I'm assuming they're going to be hiring down the road. So something to think about. At least maybe go introduce yourself there. All right, so pediatric specialty limited to dental care for children, and some pediatric dentists do, again, special needs if they're qualified, and they like to do that because it usually has to be under sedation. So restoring and maintaining teeth, the development of a child from primary to mixed permanent dentition. Mixed dentition we call when you have baby teeth and adult teeth at the same time. So anywhere from age 6 through, early teens could be mixed dentition. Employing measures to prevent dental caries and periodontal disease. Again, teaching them how to care for their teeth and avoid disease. Oh man, did I not turn it on? Oh, I did turn it on. I think I did turn it on. I'm gonna forget. I did turn it on.
Oh good, we don't have to go through the whole lecture again.
Well, it'll just run. It's because I didn't turn it off before the last lecture.
Oh.
But it may run on. So when he loads it, there may only be 2-3 lectures, because this one will be tied onto the one we just did. Okay, so it probably won't be separate, but so remember that. Okay, so again, we talked about this before. There's informed consent. Very important when we're treating children. Okay, again, anytime you deal with a minor, you've got to have consent from the parent. Not implied consent. If I find a new cavity, or if I find a new something to do on the patient, and they've already brought the patient, if I find something new, I've got to tell the assistant, or if the mom is in the operatory, I found this new area, do you want me to restore it now or no? Okay. So we need to inform them why it's a good idea to do it now versus if the patient's already numb, do it now instead of later. And usually we inform the mom, not the kid. Oops. So behavior management, there's a few ways to do it. This is looks like a fill in the blank. So fear and resistance are common reactions when children are placed in an unfamiliar environment. Many different techniques are used to achieve cooperation in the dental chair. And the first one is reassurance. So how do we, I don't know if any of you have seen me working with kids, but normally I'll get in there and start talking to them about their tennis shoes, or talk to them about their school, or just trying to build a little confidence in them.
Do you have notes on file about each child?
I don't.
I don't know if the Donics too would do that.
Yeah.
Like, oh, she played soccer, and you can see it on the.
Janice does that. They're not just on child, but on everybody.
No, that's good.
And our software has a spot there where you can make notes off the chart on, they're going on a trip for the summer or wherever. So when they come back, you look at your notes and, well, how was your trip to Alaska or whatever? And they go, oh, you've got a good memory. And I know, I've got a good software. But anyway, building trust is key. Reassure the kid. I'm not here to hurt you. I'm trying to help you. If we
don't do anything, this may get worse and it'll hurt later on, so we need to take care of it now, you know, help me and we can get through this. Just reassure the kid. That's usually the main thing. Okay, after that, then it's restraint, you know, and I don't do much of this anymore. I used to. I don't like it now. You know, I may, if the mom is there and they kind of sit on the chair and kind of hold their feet or whatever, then they restrain the kid. But as long,
traumatizing.
yeah, if the child is crying, I don't mind it, you know, because some childs will cry and they'll open, you know, and they're afraid, but they cooperate. But as soon as they start kicking, turning, grabbing, yelling, then it's not worth it to me anymore. I just refer them out to, you know, pediatric dance, which, you know, they've got different methods and their environments are set up. The new one there is a really neat office. It's all like surfer type of deal. You know,
Oh, that's cute.
really nice office. I haven't been there, but he came and he showed us pictures of it, and it looks really neat. But again, and they've got stuff on the ceiling, and it's more inviting for kids, you know, than a general practice office. But I see a lot of kids here, and I do really well with kids, but there's some kids that I'd rather refer because I don't like to restrain them anymore. It's just too stressful on them and on me. More importantly, it's just the other method is sedate them. Okay, and I don't sedate. Okay, I just refer. If they need sedation, we need to send them to somebody who's got the equipment to sedate, who's got the pulse oximeters and the monitors and any emergency medication that's needed. Because once you get into sedation and then you're administering local anesthetics, you know, you could get into some problems and you need to be able to manage them. I have taken some classes, but I just don't feel that's not an area I want to, you know, get further into, so I just refer them out. Conscious sedation, that's usually what they do, okay? The type of sedation they do. They normally mix a little cocktail for them, whatever it may be. Kid drinks it, depending on their weight, and it just kind of makes them a little groggy, you know, makes them a little sleep. They're conscious though. They're on the dental chair, and you wiggle, Jimmy, 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 and they wake up and then, Jimmy, Jimmy, Jimmy. They're awake and they're breathing on their own. Okay, and you can put a mouth drop on them, and they're breathing by themselves. And if you, hey Jimmy, and they wake up, and then they go back to sleep. Okay, but that's called the conscious sedation. So you can do it by pill, or sometimes they hit them with a ketamine dart and make them groggy, or whatever they do. Okay, the other one is another form of conscious sedation is inhalation. Okay, and this is nitrous oxide. And this we do have. I don't like to use it much, unless usually I'll use it on adults or teenagers that want it for whatever reason. And some of you may have had nitrous oxide or laughing gas. I think for little kids, personally, I think it's more scary for them to put something on their face and they're breathing, you know, and they don't know what it is. I try to, if I can't reassure them and get them to calm down, you know, I prefer not to go any further than that. Teenagers and adults that want nitrous oxide, I can do, because they know and they've probably had it before. Has anybody had nitrous oxide? No? I mean, it's kind of a, you inhale it, you start with 100% oxygen for a minute or so, then you slowly start titrating the nitrous on there. And at first you start to feel a little light, and then your hands start to get heavy, and you feel like you're sinking in the chair. It's weird. Yeah, if anybody wants to try nitrous oxide, we can put some. I mean, it's kind of like having a few margaritas, you know. Initially. Some patients like that. Some patients it freaks them out. It's kind of a weird feeling. It's a weird feeling. If anybody wants to try it, you know, we can. Huh?
Is it except for pregnant girls?
No.
Yeah.
You would.
For happy hour today at school.
Or happy, we can have happy hour right afterwards.
Yeah.
But yeah, benefit of nitrous oxide is that it has a fast onset and fast recovery with very few side effects. Okay, you can in a few, in a minute or so, you can start to feel it, and in a couple minutes you can be up titrated to where you want it, and then afterwards, when the treatment is done, you just titrate it back down slowly. Let them breathe for 2 minutes of straight oxygen, and there's no side effects really. Every now and then you'll get a patient that may have a headache afterwards, just from hangover. General anesthesia, this is the one that is usually at an oral surgeon's office. They do a deep sedation, either IV, where they really have to watch, because here the patient has pretty much lost all control of their reflexes. And you may have to breathe for them because they can't maintain their airway. You've got to have the airway open. So this is a little bit more serious. But again, with trained physician or anesthesiologist or whatever, it's done all the time. Okay, but not something I do here in my office, or it's not common in a general practice. But it is done. But the important thing is the patient loses all protective reflexes and ability to obey command. So Jimmy, Jimmy, Jimmy. Jimmy, Jimmy, Jimmy. Jimmy doesn't respond. That's not good. You got to make sure that he's still breathing on his own. The other Jimmy, 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 he wakes up. So that's the important thing. Okay, you lose all reflexes, and you got to make sure that he's breathing and have an open airway. And the recovery is a lot longer. And that's why at the oral surgeon's office, you're going to be in the recovery after you have your wisdom teeth for a while till you're able to walk. Okay, so common treatments that we do, again, sealants, we talked about that, fit and fissure sealants on primary and permanent molars. Usually you don't seal normally anterior teeth, although you can seal a lingual pit, on an anterior tooth. But you don't normally, usually on primary and permanent second molars. This is the fissure, again, that we're trying to avoid bacteria from staying down in there, because your toothbrush is not going to get down in there. And over time you start to see that staining, and you leave it there, and it ends up over time becoming decayed. So again, here's the kind of the same picture I showed you before, pits and fissures and the sealant. This is a big one we do all the time, pulpotomy. Okay, and this is performed when decay has caused an invasion into the pulpal chamber of a primary tooth. Okay, the procedure, we remove the tissue in the chamber. Okay, so we've got a cavity here, and it went into the nerve. Okay, so we go in here and we clean. We open the tooth up, and we clean up to there. And we amputate that tissue right there. Okay, so this is still vital tissue. So we're just in the chamber. Okay, this is what's called the pulpal chamber, right in there. Okay, you leave what's in the canals. You leave them in there. Okay, and that usually it stays alive. Okay, so the vacant chamber is treated with an antibacterial medicament. Either formocreosol, we don't use that. We may use Hemodent. I normally use just a dry cotton pellet and put pressure on it. And all we're trying to do is control the hemorrhage. Okay, we're trying to control the bleeding right where we amputated the nerve. Okay, so what does formocreosol do? Controls the hemorrhage. That's on the test. Zinc oxide eugenol cement is mixed into a putty, and that's one of those other type 2 cement that we talked about earlier. Zinc oxide eugenol cement is mixed into a putty and condensed with what instrument? No. Condensed. Yeah, we're going to condense it using a condenser into the pulp chamber. So we're going to fill this chamber with IRM, or zinc oxide eugenol cement. And if we're missing a lot of tooth structure, we put a stainless steel crown. If we're not, then we put a filling. This is a little diagram. Here's the cavity into the pulp. We use our instrument to break through into the pulp chamber, clean it out, again, cut it right there. Cotton pellet with formocreosol, put the paste, the IRM or ZOE in here, and then you're filling up on top. Another diagram, same thing. That's kind of what it looks like looking down after you get it to stop bleeding. Okay, here's a canal here and a canal over here. And that's how it should look before we pack it with ZOE. Okay, if it's still bleeding, then it's not healthy. You've got to keep putting something there to stop bleeding. You don't want to just fill with, if it's still bleeding, because it probably won't heal. This is how it looks like in the x-rays. Okay, you can see the IRM down here and then the filling material. Okay, so that's a pulpotomy. Pulpotomy. Okay, there's a difference between pulpotomy and pulpectomy. Okay, and the difference is in a pulpectomy, we probably, when we cut right here and we put Hemodent or we put formocreosol, it doesn't stop bleeding. That tells us there's still infected tissue down in there and it's not stopping the bleeding. So then we go into the canal and we take out what's inside. Okay, so the procedure is performed to permanent and primary teeth and involves removing both the pulp from the pulp chamber and from the pulp canals. Okay, so pulpectomy means to remove. Ectomy means to remove. Pulpectomy. Okay, so from the chamber and the canal. Pulpotomy is just the pulp chamber. Okay, you got the difference? Okay, so on a permanent tooth, when you do a pulpectomy, you're doing a root canal. And we'll talk about that when we talk about root canals. So a pulpectomy on an adult tooth is doing a root canal. But on a primary tooth, we still do it on a primary tooth to try to hold on to that baby tooth as long as we can. So all we do is we put either a cement, zinc oxide eugenol cement or calcium hydroxide into the canals, and then we put zinc oxide into the chamber, and then we put a filling up on top. Okay, so we're putting some medicine down the canals, and then a little thicker paste, and then the filling up on top. And if you look at this, and usually we'll do it on front tooth, it's the most common, but you can look at this x-ray and you can see that there's material all through into the root as well, not just the chamber. Here's a molar, baby molar, and you can see how there's material down into the canal. Okay, so a pulpectomy is basically a baby tooth root canal. Okay, on a baby tooth. A pulpotomy is just a medicated treatment on the chamber of the tooth. Beach? There's mud. So pulpectomy and pulpotomy, and that's going to come in different questions. So just understand the difference. One is just the chamber, and that's the pulpotomy. One includes the roots, and that's the pulpectomy. So if we do a pulpotomy or a pulpectomy and we don't have enough tooth structure remaining, and I can't put a big filling, then on baby teeth we put stainless steel crown. And on some adult teeth too, if they're young kids, teenagers, we'll put a stainless steel crown on a permanent tooth until they get older. But usually stainless steel crowns are on, like I told you, my front four teeth, I had stainless steel crowns growing up as a kid. I gotta find that picture. But this is what they look like. Okay, so this is stainless steel crowns, this is a stainless steel crown, and this is actually a space maintainer because they probably couldn't save that tooth there. So that's just saving that space for the permanent tooth. And so the space maintainer is a device used when premature loss of a baby tooth takes place. And so all it does is it holds that space for the permanent tooth.
No, it's permanent, so that's what we're gonna take it out, right?
Yeah, as soon as that permanent tooth starts to break through, then you pop it out. So this is kind of what it looks like
You're just moving
on
this
a model.
to pop off the bone, right?
I'm sorry?
You're just moving it because the bone.
We're moving what?
The teeth compressed to you.
We're not moving. We're just trying to, this is not active. This is just a wire to bump up on this tooth, so this tooth doesn't tip forward. I'm trying to, I think I have Yeah, all it's doing is it's bumping up to this one, just a stop, so that this tooth doesn't front forward as this one comes in. All right, so got a few more slides from the lab. Show some pictures on this here. So the pediatric lab, today we can do a stainless steel crown, we'll do a stainless steel crown. But probably the lab will be just basically mixing the IRM or the ZOE into what we need to pack into the tooth. All right, so pedo procedures, and most of the pedo procedures are either fillings or pulpotomies, stainless steel crowns. That's about it. Maybe it's extractions, I guess, of baby teeth. So here's the pulpotomy procedure. The procedure is performed on the pulp of a primary or newly erupted permanent tooth. If the primary teeth, in the primary teeth, a pulpotomy keeps the pulp vital with no prolonged adverse effects. Like I said, we amputate the root, or I'm sorry, we amputate the nerve at the entrance of the canal, and the remaining nerve tissue is vital, meaning it's still alive. Okay, so that's the important thing. So the goal of doing a pulpotomy is to keep the tooth in there as long as we can. Okay? Because if not, we're taking the tooth out. So by doing a pulpotomy, we keep the tooth root basically alive, or the tooth alive, and that baby tooth usually goes through normally, and he loses it, or the patient loses it normally without premature loss. If we don't do a pulpotomy, then we lose the tooth. Okay, so it keeps the tooth vital. And again, you got formocreosol. I just use cotton pellets. Zinc oxide eugenol is the paste that we put in the chamber, or IRM. If we're going down into the canal, we use this guy because this guy resorbs. IRM does not. So when the root is resorbing, if you've got IRM down in here, you're going to have IRM inside the area where the other tooth is coming in. So if I'm doing a pulpectomy, I'm using this or a calcium hydroxide. If I'm just doing a pulpotomy, I use this because my pulpotomy is going to be up here, and once as the root resorbs, the IRM doesn't have to resorb. Okay, but if I'm going into the canal, I have to use zinc oxide eugenol. You don't need to know that, but FYI. Burrs, we need burrs. That's always good. So we numb up the patient. The first thing that we do, and this is a test question, using a high-speed handpiece, the dentist creates an access opening into the pulp chamber to do a pulpotomy or a pulpectomy. Okay, so the question asks you, what's the first part of the procedure to do a pulpotomy? Anesthetize, and then the dentist cuts into the pulp chamber. Okay. Once we expose the pulp, we kind of amputate with a slow speed or a spoon or something. We amputate the pulp right at the entrance. Then you either have sterile cotton pellets. We don't use sterile cotton pellets. We just use cotton pellets, and either hemodent or just pressure. And the important thing is we're stopping the hemorrhage. Okay, that's all we want. Stop the bleeding. If we can't stop the bleeding, then we can't fill. Okay, once the bleeding stops, then we fill and rinse, or we rinse the chamber, and we start to fill it with a zinc oxide eugenol, with you guys will mix. And important here, the final restoration is now placed. If there's minimal tooth structure lost, an amalgam or a composite filling can be placed. Okay, if I've got enough of the tooth structure left, I can put a filling. If I don't, if I try to put a filling, especially on a baby tooth, it's going to fail. Okay, so we use a stainless steel crown. If I don't have enough tooth structure to put a filling, you put a stainless steel crown. Still cold.
I'm breathing.
So again, this is kind of the same thing I showed you before, a picture. Hey, this is what it should look like before you put your IRM or the ZOE paste. It should be just look like that, not bleeding. You can see blood in there, but it's not oozing out. And just directly on that, you put your zinc oxide eugenol. Now, what does the zinc oxide? What is eugenol? What does the ZOE have or the IRM have?
Eugenol in it.
Yeah.
It's the
Soother.
Yeah.
Yeah.
Cloves.
Yeah, oil of cloves. So we
Yeah.
put that on the nerve here. It's actually going to feel good.
Yeah.
If the patient's numb. If they're not numb at that point, it's going to bother them. But if they're numb, when the numbing wears away, it's going to be fine. Okay, again, that's an X-ray of a pulpotomy there. Here's the permanent teeth developing underneath.
So if they have either a pulpotomy or a pulpectomy, it just pushes it out when their baby teeth fall out? Or?
Correct.
Okay, so like what happens if you're going all the way into the root? It just comes out with the tooth?
If you're
or-
going into the root, you have to use zinc oxide eugenol. Okay, because that will resorb and wash out as this comes up. It dissolves. Well, if you put IRM in here,
It's gonna
then,
stay.
yeah, it's going to stay. You're going to have little bits of IRM inside the gum.
Okay, so it just stays there forever then?
Well, it'll probably over time work, the body pushes it out. You're going to have a piece of IRM coming out the side of the gum, you know, when he's 15 or something. But you'll take an X-ray and it may show
Still in
there,
there.
still in there. Okay, stainless steel crown. Let's see. What do you need to know? Don't drop these. There's probably 3 or 4 in each compartment there, and you can look at them or have Kim show you. We've had them, the girls drop them, and it's a hassle to try to put them where they belong because they all look alike. Unless you're looking, you got to look at them. They vary in size, and then to figure out which side they are, it's hard. But there's pre-contoured, meaning they have the shape, kind of like the bell shape of a natural tooth, or there's the straight contour, or non-contoured. Okay, and again, it's dentist preference. I like these. If they're non-contoured like this, then there's these little pliers that you can, after you fit it, then you get those pliers and you go around the tooth and you give it the shape you want. And then these crimping pliers, you just kind of bend the edge so that it grabs onto the baby tooth. If we have time, we'll do one of those, but I don't know. So that's just saying what, and you're gonna mix when you put. Hey, Nikki, how are you?
Good, and you?
Good. Welcome. We jumped to.
Just came to visit.
This is one of our recent graduates.
Yeah, I think I seen her picture on Facebook.
Yeah, I
Yeah.
did. I just.
Oh, yeah.
Yeah.
That's very
Nikki.
organized.
Nikki, welcome. Have a seat.
Is that, nah.
I think he's
Are
back
you
there.
back there?
Yeah.
Okay.
Go ahead.
I'll come back in a minute.
All right.
She's like, no, I don't want to join.
She's had enough. So you have to select the size. So again, they go from you select whatever tooth it is, and there's first molar, second molar, first molar upper right, first molar upper left, whatever. You find what you want and you size it, and then once you size it and pre-fit it, when you do mix this cement for this on a permanent crown, you don't fill it up. On these, because it's not like custom fit to the tooth, you're trying to fill in some voids, you're gonna like overfill this stainless steel crown. And I've had some assistants coming through, and when they mix it, and they just kind of line it. No, because I'm gonna have voids in there. I want to overfill it, and when I push it, I want excess coming out, because I want to make sure I've got everything full in there. So on the stainless steel crown, usually you want to overfill. On the other crowns that we do normally, you want to line it because I don't want too much to clean. But here I do. So crimping pliers and you shape it. We don't need to know that. Cement it. So this is kind of what they look like. The tooth is prepared. That's not how we prepare stainless steel crowns though. But you put it on, and after you cement it, you make sure you take that number off. Just get a spoon or something, and you can just roughing it up just with a spoon excavator, and it just falls off. Don't let the patient go with
Home
a
and
D.
be like, why do I
Yeah,
have a
yeah.
D5?
Why does it say D5? But yeah, I've seen it like that where they forgot to take it off and the patient comes back and they still have D5 or L, whatever. Okay, space maintain, these were the images. So here you have your permanent teeth coming in. You have your first molar, second molar, and your 6-year molar here. Okay, so if this one is lost prematurely, as this one erupts, this guy's going to tip because this guy's going to want to push this way. And so what happens to this guy? It gets locked in, and then you've got more trouble than if you just went ahead, took an impression, and put a space maintainer there. Because your 6-year molar starts to come in here, this tooth is going to drift forward. So all this is just a brace to keep it there. It's not pushing anything, it's just cemented. And so we cement it on there, and it should stay there. So this kid is probably, he's not even 6 yet because he doesn't have a 6-year molar. So he's probably 4 or 5. So this is going to be there till age 10, that space maintainer. So, and sometimes it'll pop off. They'll chew on candy apple or something and it pops off. You come in, you just clean it, and just put it back in, just re-glue it. Usually they make it through, they're pretty resistant. But if it does pop off and they don't come back, then it's the orthodontist has to push everything back, and it's hard. Yay! Was that the last one?
Yep.
Ooh, we got finished early.
You predicted that though.
I'm a magician. We got time for the quiz today.
Works for me. Everybody let me know.
Any questions? Colder today than another day?
Last week I was pretty cold, but I think I'm getting sick.
Drink your vitamin C.
Yeah, I thought next Friday we didn't have class. I was telling my son, oh, next week all you have to do is take me to my doctor's appointment. And then I was looking at the thing on the page, the student got it online, and it said that there was class next week, and another week after that there's no class. I was like, oh.
Yeah, next week it's I'll talk about it right now. But you concentrate. Nobody's claimed the $1 bill yet. Still right here.
You're still on that.
Accept tips.